Cool. So my name's Cate Bailey. I'm a consultant psychiatrist. I've fairly recently finished my training, so also congratulations to Camilla as well with that. So I work clinically in East London, largely with older adults, but also in liaison in the acute hospital. But my research is looking at something kind of allied, but slightly different. And I'm looking at the experiences, understanding and conceptual models in people who have functional neurological disorders, and I'm doing a mixed methods study. I've got many collaborators and supervisors who are kind of listed below. I hope one day that this slide won't be necessary, but I think for now it very much is, because functional neurological disorders are something that many people haven't heard of or don't necessarily understand particularly well. I would add that it's FND Awareness Month actually in April, so if you're interested, please check out the FND Hope website and a blog that I wrote for MHI UK this month on FND and some of the challenges that people experience. But FND essentially is neurological symptoms which are not caused by neurological disease, so not a particular lesion or a stroke or something like that, but they do have distinct clinical features and symptoms, and they're essentially caused by a problem in how the nervous system is functioning rather than a lesion. Exactly like I mentioned. So people can experience things like seizures, tremors, paralysis, numbness, cognitive problems. And these are really common disorders that account for kind of up to about 16% of neurology outpatient visits. It's as common as MS. But what people experience is very long delays to diagnosis, very negative experiences with healthcare professionals, and often kind of a sense of sort of hopelessness and being abandoned. So we know that people with functional seizures and weakness often feel that their illness is kind of very mysterious, is going to be permanent. We know that stigma is higher in those with functional seizures compared to epilepsy, and that's quite a striking finding because epilepsy in and of itself is quite a stigmatized disorder. And a recent study from FND Hope found that a very large proportion of people had felt dismissed or disrespected or not believed by healthcare professionals. People often feel very dissatisfied with the explanations they receive. They feel very powerless and abandoned. But like with many other disorders, getting the right diagnosis early, having kind of good care, high satisfaction is associated with a positive outcome. And like anything, understanding what's going on with your body and having a name for it is very important. So St George's, where I am conducting my research, offer a novel multidisciplinary education session, which early studies that they've done has found that it's increasing understanding, hopefulness and belief in treatability. And that's a session that takes place now online a few times a year with kind of a psychiatrist, a physiotherapist, a neurologist, expert by experience, a psychologist, and goes through some of the kind of explanations and talks about what people can expect from treatment. So my study then is looking sort of at a number of different things. So one part of it is to look just at the kind of lived experiences, understanding and conceptualization, how people understand their illness, so people with FND. And a secondary aim is to look at how people experience attending this education session. So you know, how do they experience the explanations that they're given in that session? Do they kind of land well? Do they make sense to them? So it's very much a exploratory and hypothesis generating study. So like many people, things were quite derailed by COVID, but the progress that we've kind of made in the last sort of year or so has really been that we've adapted everything to kind of an online study, and that brought its own kind of ethics related issues, but we received ethics approval in kind of late November last year, and have kind of gone headlong into recruitment now. So things are moving, which is exciting, I think, after such a long delay. So there's lots of different parts to this study. I'm going to focus on a couple of them today, but we're doing a systematic review of qualitative literature, which looks at the lived experience of motor and sensory symptoms. And the focus on that is because much more work has been done previously on experiences of functional seizures compared to the kind of motor symptoms. And that's been, the protocol's been published on Prospero. So we're working on that alongside, because that's also going to inform some of the qualitative work that we're doing. We're going to be doing some in-depth interviews looking, using phenomenological analysis like Camilla's study, looking at the kind of lived experience of these symptoms. And we're also doing a quantitative study, which I'll talk about shortly, as well as a think aloud study like Kerry mentioned with her study of suicide experiences. And we're also doing some focus groups. So lots of things happening in parallel. But the things that we're focusing on mainly at the moment are the quantitative study, because that's very much linked to the education sessions. So we had the first this year in January, where we were able to recruit some people from that. And there's one coming up in May. So lots of work in trying to recruit people for this at the moment. And what we're looking at is just any people with any type of FND who are going to be joining online for the session. And we're asking them to fill in some online surveys before, immediately after, and a month after their session. And we're trying to capture kind of illness perceptions and experiences, mood, measures of their functioning and disability, and also focus on stigma and trying to kind of understand that from a number of different measures. So talking about the illness perception questionnaire, so we know that illness perceptions and kind of people's beliefs about their illness, their perceptions of the hope for treatment, whether their illness can get better, or and what sort of sense they have of control over their illness is really important in terms of recovery and engagement with treatment. And the IPQ has been used in lots of different physical and mental health disorders since it was sort of created 20 years ago. So one of the things that it looks at is kind of illness representations based on the Leventhal's common sense model of self-regulation, which is just a way of kind of understanding how illness affects the self and kind of the body. It is sensitive to change, so that's one of the reasons that we're using it, and also because a large systematic review looked at the kind of outcome measures that would be important to measure in FND, and illness perceptions was one of them. We're particularly looking at stigma as well, which is a kind of novel aspect of this study, because although kind of subjectively, and I guess the reports from lots of people and studies that look at healthcare professionals have shown that there's lots of kind of negative interactions that occur, and that stigma is a very, very big problem in FND. I don't need to really explain too much about what stigma is to this group of people, but I guess one of the things that we know is that it exerts a very powerful influence on clinical interactions, and that there's also an aspect of stigma that affects not only kind of the discrimination and kind of systemic issues, but also the sense of self and kind of how people feel about themselves. So we're using a measure, the SSCI-8, which looks at enacted and internalized stigma. So the enacted stigma is kind of what have you experienced that is stigmatizing, and then the internalized is kind of how has that then affected you, how have you incorporated that into your sense of self. And then a further aspect of stigma is the CIASS, which looks at kind of then what do you then anticipate in the future in terms of interactions, because we know that if you've internalized something or had lots of negative experiences before, then you will obviously go on to expect those in kind of future interactions. So asking about, what do you expect, how do you expect healthcare professionals will treat you? So we're looking at all those different kind of aspects of stigma. And in terms of the think aloud, which is a methodology that I kind of only came across in the course of developing this study, and actually kind of arose from feedback from FND Hope, so the charity FND Hope, who looked at our protocol and sort of highlighted that some of the questions, particularly in the illness perception perception questionnaire might actually be a bit problematic for people who have often had experiences where they've been dismissed by healthcare professionals or kind of perceived as if they were malingering. So some of the questions were highlighted as potentially offensive, but also there's also a body of literature looking at the need to actually adapt the IPQ to make it much more sensitive and appropriate for particular disorders. So these think aloud techniques have been used to do that with things like atrial fibrillation and diabetes, to adapt the IPQ to make it more kind of sensitive and appropriate. So we've added this aspect in, and we will be taking a subsample of participants and doing Microsoft Teams interviews with them, sharing a screen and going through the survey together, where they kind of literally just talk through what they're thinking as they're doing the questions. And I guess we've done a couple of interviews so far, a couple more coming up. I guess I would say it's very illuminating already, sort of as a kind of adjunct or to understanding how questions are interpreted. People really often get very different things from questions than what you would intend. As a kind of example, with one of the stigma questionnaires, one of the participants rated anticipated stigma very low for employers. And that was kind of a little surprising in a way. But as they talked more about this, that was because they had no intention of telling their employers about their illness. So just a kind of one example of how the questions can kind of be interpreted in a way that might kind of falsely give different results. So really interesting methodology. I'm looking forward to kind of continuing to use that. So that's where we're at the moment. It's sort of full steam ahead with recruitment and getting to sort of very much more the interesting part of the study now. It's not theoretical anymore, it's actually happening, so that's nice. And thanks as always to MHI UK for the support with this, and that's the link to the blog for April FND Awareness Month. Thank you.
Thank you very much, Cate. That was really fascinating, because these are a truly abandoned sort of group of individuals with FND, or they certainly feel abandoned. So really interesting. And I would urge people, if you haven't read the blog on our website, it's really interesting and very good. We've just got time for maybe one or two questions. Right, is anybody? I can't see any hands raised at the moment. Can you just to start off, can you just describe, is it difficult to recruit the patients for your study, or have you found it very straightforward? Are people reluctant or not?
I think what I've found is the survey has been a little bit tricky. We're sending out kind of email invites along with the education session, and that's been kind of sort of, yeah, getting, I suppose, sort of the first time around, like kind of 25% or 30% kind of response rate. Whenever we contact people by email, there's kind of issues with emails getting lost and that sort of thing. In terms of the people I've spoken to about the Think Aloud study, people are much kind of keener. So when we have a phone conversation, I found people kind of very enthusiastic to kind of help. And most of the responses have been, you know, really glad that someone's doing some research into FND. So it's sort of a mix. I think that the personal response and having a phone conversation often works a lot better. Yeah.
Yeah, thank you. Camilla, you've got a question.
Thanks, Cate. That was a great presentation. I was just wondering whether in your research so far you'd had any crossover with long COVID at all. Just wonder what your experience of that is.
I think there's definitely a lot of crossover with long COVID. I haven't sort of looked particularly at, I suppose, much except kind of picking up what's going on kind of generally and how the experiences of people with long COVID very much kind of mirrors the experiences of kind of chronic fatigue and other sort of illnesses that are contested within the medical community, and the kind of importance of kind of people with lived experience actually driving research agendas, because I guess that's one of the really exciting things about long COVID research, and that the kind of groups like the Body Politic and things like that kind of highlighting from the very beginning, sort of, and getting people to take notice. I think there's going to be a lot of sort of overlap, and certainly my supervisor Tim is actually involved in setting up kind of long COVID clinics and so on. I guess the thing is always with these sort of conditions is trying to learn from the mistakes that have gone before with illnesses where people, you know, as healthcare professionals, we don't understand, and the risk is kind of dismissing people, and that tends to happen kind of time and time again. So hopefully we can do things better this time around.
Thank you. Thank you very much, Cate. That was a really great presentation. Just in the last couple of minutes, are there any general questions that anybody would like to, are there any general questions about the MD-Res and so on that anybody would like to hear more about? I mean, I guess that I will ask a question, and any of you can respond to this. I mean, it seems to me that that it is extremely demanding to do to carry out this research over a number of years while you have really demanding clinical commitments as well. And I just wondered if one of you would like to say something about that experience of balancing the research with your clinical commitment.
I can start. I'm sure others have things to say as well. So I was lucky in that I had a funded year to do my data collection. So that was on a larger project, but I think that was really helpful for me. I think the other thing that was really helpful is we're so lucky in psychiatry training to have a day a week to devote to a special interest. And in my case, that was research throughout my training, or my higher training at least. So that's how I've been managing to do it. And I think there's real benefits to doing research alongside your clinical work. So I think I know you spoke about sort of real world applicability. I think like that's what I want to see, you know, because I'm a clinician, and I'm keen to see like my work actually have impact in clinical practice. And I think you really maintain that drive and motivation by doing your clinical practice. But yeah, it's not easy is the other thing I'll say, and you certainly have to learn, and it's things I probably learned by making mistakes, but by trying to be sort of boundaried around your time, and trying not to take on too much, and learning to say no and all those things. And I think those are things you learn by doing them completely wrong, and then sort of realizing that you can't do it that way, and you need to be more boundaried, etc. So I don't know if others have similar experiences.
Camilla.
Yes, it's a really good question. I just like to also incorporate having 2 young children, and sort of taking maternity leave combined with that. So yeah, the three things. I think, yeah, it definitely is I think perhaps a struggle. And oh no, we're going to finish very soon. But that's why I've invested so much. I'm applying for this job as a consultant, where I've been talking to them, and they say that there's a possibility of basically me having 2 days research a week. And this is what I'm really going for at the moment, to really have those days set aside, where I can continue doing this research, you know, on the same day, and it'll be the same job, and everything stays the same. And that stability, I think, will really help juggle the 3 things.
Thank you. Well, have you got one word to say, Cate, right at the end?
I think just, yeah, the future, I guess, is trying to find job plans where it's possible to do both, because I think it's very nourishing to be able, and helps with sustainability, to be able to have different things. So definitely. Yeah, anyone's out there thinking about consultant job plans, putting in time for these kind of things is great. They both feed off each other.